welcome everyone, and thanks again for joining. On behalf of the Global Healthcare Resources Group, I'm very excited to welcome you to our next portion of this webinar, looking to make revolutionary changes to your healthcare program, precision medicine, and pharmacogenomics for employers. Today's webinar is brought to you in partnership by Wellvia, and we're very, very blessed to have the three very professional speakers. We've got Dr. Ronald Leopold, who's the Chief Medical Officer of Lockton, and you're just perfect for precision medicine and pharmacogenomics. You know this so well. And of course, before I introduce the rest, I want to share just a couple of housekeeping notes to those of you that are just joining this portion of the call. Once again, this does count for CEs, so both SHRM and CCWS, as well as our SICS, CVBS, and CRIS designations. Again, I'll email you instructions post-webinar on how to self-certify. Again, we'll have polling questions for those of you just joining us. Hopefully you can participate. Just look there on the right of your screen. You'll see the polling question area where you'll be able to participate in the poll, and you'll have a few seconds to participate in our polling. And then we do have open Q&A. Just as a reminder, please type your questions in the Q&A box, because if for some reason we do run out of time and we can't get to all of your questions, we will definitely get back to you with answers as quickly as we can. And so it needs to be in the Q&A segment and not in the chat section, so that we can keep track of those questions and get back to you as a team after the event. Again, this will be available for you 48 hours from today, and we'll be emailing it to all registrants. You can listen to it again, or as I mentioned before, you can share it with your colleagues. And so before I welcome all the speakers, I want to quickly ask a polling question just to get everybody back involved. So we're going to ask one more question. I'd like to know what most drew you to attend this webinar. Was it looking to reduce your high claims costs, looking to improve health of your employees, looking to attract and retain top talent, or looking to learn more about pharmacogenomics or genetics as an innovative employee benefit? So we'll just give you a second to make those answers. As I look at the poll here. Okay, just a second here. All right, thank you for participating, everyone. So it's all around the board here. It looks like the majority are looking to reduce high claim costs, of course, improve the health of their employees, is followed by, secondly, or actually equally, and then looking to learn more about genetics and pharmacogenomics as an innovative offering for your employer. So that's very telling, and we're glad to have all of that information before we hop right into the next part of this section. So I'm going to get this discussion started. So please welcome me in joining today's speakers. Again, I'll introduce Dr. Ron Leopold, Chief Medical Officer, Joe Connolly, Senior Vice President of Strategy and Business Development, Troy Moore, Chief Scientific Officer for Kylos Genetics, and we're just super happy to have you guys with us today. Joe, I'll pass it over to you so you can do a quick intro and welcome.
Okay, thanks, Jenny. How are you doing today? Are you doing all right? Okay. I'm trying to engage you in conversation. You're not fighting.
I'm sorry.
Okay. Precision medicine, pharmacogenomics for employers. What I want to share with you is the following. There's a lot happening in the areas that you're going to hear from Joe and Troy, as well as others in the industry. We're seeing ads for Ancestry.com, 23andMe. We're reading about expensive genetic cures, etc. There's a lot of science behind it, and the science can be very, very confusing. The difference between testing for somebody's predisposition to breast cancer is very different from testing someone with the tumor of somebody with breast cancer for what medicines they'll be responsive to, are two poles in the continuum of possibilities here. My job is the following. One is I want to try and present it to you in as easy a way as possible so that you can understand it. And I think that when you hear from Joe and Troy, and I think we're going to go in that order, that's why I'm naming them that way, they'll also do their best to okay, Troy, then Joe. Thanks, Joe. Joe's interacting. All right. I'm going to play with Joe more than Jenny. I think what my job is to help explain some of the science, and then the second piece is help you think about how does this apply to employee benefits. I'll presume that everybody on the webinar is here in some way connected to what can the employer in HR and benefits do, introduce, consider to benefit their business goals. So I start with new medical technologies, and I want to just mention that, and I should give my background. Chief Medical Officer at Lockton. Lockton is an employee benefits broker. We work with companies around the country. I'm a resource in the national practice for Lockton around the country and get frequent questions on this area. I put this slide in here only to show you that what we're talking about today is part of a broader continuum that I think is revolutionizing what we need to be focused on in employee benefits. And that is that there's a lot of terrific, cool, wonderful technology out there. There's a lot of noise to that signal that has to be considered, and there's considerable cost with a lot of them. So although we're looking at the third of the middle bucket today in genomics and gene therapy, let's also recommend that recognize that this is part of a continuum from pharmaceuticals, medical devices, radiation emitting, and vaccines and blood biologics, all of which are introducing new, previously unforeseen types of cost-benefit considerations that we have to be prepared to face. I am unable to advance the slide. Jenny, can you do that for me? Okay. So, I was listening to the last presentation, and I want to run through this, but I'm going to give you a caveat with each of the points made here. When we talk about genetic testing can diagnose a disease. However, most diseases are not diagnosed by genetic testing, and that's important to recognize. However, certain conditions we can detect by genetic testing, and in some cases, it is only through genetic testing that we can verify a condition. So that's important to understand. So we have an ability now to understand things. And by the way, genetic testing for disease has been around for as long as everybody on this webinar has been alive. We are steadily improving that. Look for more going forward. Predict how severe your disease might be. The science is very early on that. And in some cases, the science just gives a suggestion or a probability that you may be prone to something more substantial than the next person without the particular gene or cluster of genes that we're talking about. Pinpoint genetic factors that cause your disease. Choose the best medicine and correct dose. Pharmacogenomics, and you'll be hearing Troy and Joe in that order talk about pharmacogenomics. I'll introduce the topic. Exciting area, and probably one of the most important for employee benefits decision makers to consider. Discover genetic factors that increase your disease risk, and find genetic factors that could be passed to your children. That's the overview of genetic testing. And there we go. So the two topics that I want to cover now is precision medicine and pharmacogenomics. Precision medicine, also known as personalized medicine, reveals or looks at or examines genetic factors that increase risk of disease or condition. Are you prone to heart disease? Are you prone to breast cancer? Are you prone to, if you were to get something, a severe version of that disease? That science is improving on a regular basis. And so what we're looking at today is a broader list than we looked at 2 years ago. And 2 years from now, we're going to be looking at a whole lot more. The horizon here is tremendously exciting. The challenge is, if I test positive for a predisposition, what should I do and what can I do? Keep that in mind. Precision medicine revealed genetic factors that increase risk of disease or condition, and more targeted prevention, early detection, and treatment of disease. Pharmacogenomics, on the other hand, what if I have a condition, what medicine is best for me? Or put a different way, I see 4 faces on the screen right here. We could give the same medicine to all 4 of the people that you're looking at, and Jenny might rapidly metabolize it and need a much higher dose. Ron might be perfect. I'm just right. I'm going to be the just right guy. You give me the normal dose, that's fine. Troy may need double the dose, and Joe may have a really violent reaction to the medicine. Pharmacogenomics is based on a class of drug or an individual drug, genetic testing that helps us understand which out of a couple of different medicines in this class is best for you, and given that selection, whether we need to dose you on the lower side or the higher side. Optimize the selection of choices, avoidance of side effects, discontinuation of useless drug therapies, etc. Let's move one more on the slide, okay. So for precision medicine today, what am I predisposed to? On the left, you see some of the genes that we are able to look at today that says if you test for a certain, if you have a certain phenotype of the APC gene, you may be predisposed to certain colorectal cancers. Same thing with CDH1 gene in stomach, breast, melanoma, pancreatic, ovarian, and uterine. The challenge is, if you have the gene, it doesn't mean that you will definitely get the cancer, but it does mean that you should be more alert, more wary, and more vigilant. The other thing is, it tests for breast cancer is a number of different cancers. These genes typically are tied to a small subset of colorectal cancer, of breast, of pancreatic, of uterine. So if you test positive, you're predisposed to that particular subset, not all uterine, not all ovarian, not all breast. That's important to recognize. And then finally, if you don't have the gene, you still might get any of the cancers that we described. How do you deal with that? If we're all struggling to understand that, how about everybody else? Medical conditions, some aortic anomalies can be detected, some heart arrhythmias, heart beating patterns, some cardiomyopathies, certain forms of high blood pressure, not most of the blood pressure that we deal with a large population, but a small subset can be identified. Familial hypercholesterolemia, so not the high cholesterol that many of us get based on lifestyle, but these folks have sky-high cholesterol levels, and if they test positive, that explains why their levels are so sky-high. And you see some other conditions as well. Let's move forward. Okay. So, precision medicine in employee benefits. The two things that we see are generalized testing. Let's make this testing available to everybody. Employer-sponsored, or what we're increasingly seeing is voluntary. We will make available at a discounted case, or make available if you choose to use it, and subsidize it or even pay for it all out. Test information or provides information to the tested individuals on their predisposition, their risks and propensities for certain medical conditions, and in some cases, responsiveness to certain classes of drugs where there is a genetic test for that. The Good thing about that is it provides a lot of information. The challenge, especially for those of us in employee benefits, is if you get that test and you test for anything, it is very easy to misinterpret what that means. And as slick as our technology is, at the end of the day, somebody who's been tested, who tests positive for a predisposition for one of the things that they see here, or who test positive in any of those instances, they're going to need telephonic support. They're going to need voice-to-voice, high touch, helping them understand what this does mean and what this doesn't. Some of what I've tried to do on this call. In other cases, we do see targeted testing. We know that, we may be able to test for 100 different genes for health disposition, but honestly, it may be that there's only about 20 of them that are actionable. So we do sometimes see employers working with genetic testing companies and other management companies identifying a specific profile of genes that have the highest value and the highest payoff in terms of informing people and their providers of predispositions and conditions that can help them make better decisions in their care. That's where the rub is in all of this. As these new technologies come up, we have to be able to deal with, and why telephonic support is so important. Creating a false sense of security with false negative results. So if you don't test positive for BRCA gene, you still could get breast cancer. And that's important to understand. That's not a get out of the mammography ticket whatsoever. Creating a false sense of anxiety with false positive. Some of these tests just say you're a little bit more likely to get this kind of heart condition, for instance. So not viewing that as a predictor of certainty, but rather couching that in terms of what it means. Recipients who get a positive test can say, I'm predisposed to a condition. There's nothing I can do to prevent it. I'm predisposed to a condition. Changing my behaviors aren't going to make a difference. I tested negative for the condition, so I don't have to worry. Those are all what we don't want happening from genetic testing. I still haven't figured out. There we go. So let's move to pharmacogenomics. Pharmacogenomics is testing for somebody, testing whether somebody and how somebody responds to drugs. So it's analysis of the genes that you have that influence how you might respond to medication. By the way, this isn't all medications, and in many cases there are variations in response that either there are not a genetic sequela to, or that we haven't discovered yet. But what you see on the right are the drug classes: cardiovascular, psychiatric, pain medicine, some cancer, so some oncology, and a few others. In other words, where this works well, it works well, but it doesn't always work well. And that's why, and that's why, go back if you don't mind, that's why it's important to make sure that you make those selections. Maximize drug efficacy while minimizing adverse drug reactions, picking the right drug and the right dose. Move forward, please. So some of what we do with employers is we try and what are you trying to accomplish? What are you trying to accomplish? What do you want out of this genetic testing? And so we will put, whether it's precision medicine, I want to test for the predisposition of conditions, or how are people going to respond to drugs? What does the new capability offer? Is it scientifically proven? What's the upside of offering the testing? What's the so what? What are the action items? And are we connecting the dots to make them happening? What's some of the potential downsides to offering the testing? And we talked a little bit about people misinterpreting those results. Do the benefits of testing outweigh the costs? Does the medical carrier pay for this testing? Great. If they don't, Why don't they? And in some cases, they may not have looked at it yet because this stuff is coming off the presses pretty quickly. In other cases, they may have looked at it and they may have determined, honestly, there's more of a downside than upside. And that's something that we should consider carefully. They do pay close attention to that. And what are the ethical and legal ramifications of including any kind of genomic testing to your benefits plan? I think I have one last slide. So when we're looking at vendors, and I'm going to pass it on to Troy more next, we want to understand what's being tested, who's doing the testing, how's it being administered, confidentiality, and who's going to see the results. So some of the questions that I will ask is, what labs are being used, how are they credentialed, and how can we be assured of quality? Second is, most important, how are results being delivered back to the recipient? So in other words, are they getting a report? What does the report look like? What does it tell them? And how do they get more information? Is genetic counseling mandatory? Or are there certain conditions that come up that trigger mandatory considerations? How is the treating physician looped in, if at all? What are the costs of testing, and what are you testing and what are you not? And how are you making money on the process? So in other words, what's your business model? And then finally, are recipients able to maintain a connection over time? If I get my genetic testing today, 3 years from now, they can run that same database of my genes against a whole other set of algorithms that will test for some of the findings that medical science has opened and unearthed in the next 3 years. That's another really powerful piece. With that, I may have taken a little bit more time than I planned on, but I pass it on to Troy.
Thanks, Ron. That was a great introduction to pharmacogenetics. So I'm going to speak today on how do you apply these, right? What is pharmacogenetics in a little bit more detail, and how do they get applied? Okay. So when we talk about metabolism, typically we hear things like, she's thin because she has a high metabolism, or he's a little bit heavier because he has a slow metabolism, right? And what we're really saying is this person takes in food, uses it for energy, and then eliminates it from the body, right? That's metabolism in general as we think about it. What we're talking about here today is really drug metabolism, but it works the same way, right? So how do we take a drug into our body, get the benefit from it, and then eliminate it from the body? And if that process doesn't go as we expect, what are the ramifications of it? What are the adverse reactions that can take place? So for most of the population, let's say in any given 30-day period, you could ask, and about half the people have taken at least one prescribed medication. In fact, for about 15% of the population, they've taken 5 or more prescribed medications in the last 30 days. Okay, and that tends to get worse as we get older. We find ourselves on more and more medications, and yet we use a more trial and error approach in prescribing those medications. So physicians will develop a repertoire of drugs that they're comfortable with. They prescribe those, and they generally work. However, about half the population, as you can see here, will not metabolize one or more of these medications appropriately. Okay, so what does that mean? That means, as Ron was saying, that they can eliminate it from their body too quickly or too slowly, and it builds up into their bloodstream. And all those kind of things can lead to changes in the way the medication should work for you. So, as he was saying, 2 individuals could be of the same weight, right? Therefore, typically they would be dosed the same, but yet the blood levels of those drugs in their bodies can vary wildly, up to 600 times difference, right? And we know that about 15 to 20% of these differences are accounted for by genetics. So much like what Ron was saying, genetics isn't everything, right? There are environmental influences, there are things that we don't understand yet, but it accounts for a portion of it. However, for certain drugs, certain classes of medication, genetics can account for about 95% of the variation, right? It's very well understood now that those medications are greatly affected by our genetics. So to give you a flavor for that, these generally are not very esoteric drugs. right? We've all heard on the news about this one drug that costs, $500,000 a year, but you really have to take it. So that's not what I'm talking about here. What I'm talking about here are very standardly prescribed medications, things like clopidogrel or Plavix for a heart condition, right? Warfarin for blood clotting, oxycodone for pain control, right? In a recent study, 2015 and 2016, 23,000 people underwent pharmacogenomics testing as part of this one study. And about 17,000 of them, or 75% of them, that were on these medications were recommended to make a change. Some of them required an immediate change. Some of them, it was recommended to change to get a better benefit from it. At Kylos, we use DNA sequencing for this, and this is to get to the best answer the quickest, right? And so when we step back and think about the genome, the human genome is about 3 billion bases, right? And so think about that as like a novel, right? And if you're going to read a novel, you tend to read sentences or paragraphs, right? And so if there's some mistakes in the printing of that novel, and you're reading it in context, then you can make out those changes. Your brain will fill it in, right? And so you immediately can identify what are those changes, and that's okay. You still get the context, right? And that's what you do with sequencing. You're able to read it in context. Most other technologies that are utilized for doing pharmacogenetics testing only look at single bases. So out of those 3 billion, they look at one base here, one base there. And so, yes, occasionally they'll pick up the changes, but then they miss a lot of them because they're not looking at everything. Okay? And that's what DNA sequencing allows you to do. It allows you to look at the relevant portions of the genome in great detail with a very high quality. Why is that important? Right. Well, it's because these genes are very complicated, can be very complex, but at the end of the day, there's a few of them that make a very big difference. Remember I said that there were some genetic effects at some drugs, at 95%, right? There are a couple of different genes that are responsible for that. The cytochrome P450s are here listed as shorthand of CYP2D6, CYP2C9, CYP2C19. These are responsible for metabolizing about 25% of all medications. Okay? And most people are not normal metabolizers because of some change in one of these 3 genes. Okay? And that's going to affect a lot of the medications. You might be lucky and you might be put on some medications that you're perfectly fine for. Your CYP2D6 has some variants in it, but your CYP2C9 and 19 are normal, and the drugs you're taking are only metabolized by CYP2C9. And so you would experience the normal effect of those drugs. However, if it's one of the drugs that's metabolized by CYP2D6, and you have a change in your CYP2D6 that causes it not to perform adequately, then you might not get the benefit of that drug, or you might experience a serious side effect from that drug. One such example of that, one we're all pretty familiar with, Tylenol-3. If you go in for oral surgery, or you have a child that's broken a bone, they may put them on Tylenol-3, which is acetaminophen, Tylenol plus codeine, right? And that's meant to alleviate the pain very quickly. Codeine's a prodrug. What does that mean? It means that when you take it, the codeine itself does nothing for you. Your body has to use CYP2D6 to change that codeine into morphine. And it's actually the morphine that gives you the benefit, the pain relief. Okay? If you do that too fast, then you effectively get too much codeine or too much morphine too quickly, and you experience an overdose at a normal dosage that should be fine for people of your body weight, your age, those kind of things. But because your CYP2D6 works overtime, you get too much of it too fast. The opposite can also be true. If your CYP2D6 does not work well, then you metabolize too slowly. You think, okay, well, that's not so bad, right? I'd rather not get an overdose. But in fact, it can build up in your bloodstream. Your body, when it's metabolizing it, is trying to get rid of the drug. And if it can't get rid of it, then it builds up in your bloodstream. And then, 2 hours later, you take a little bit more. And then 2 hours later, you take a little bit more. Maybe you're not getting the relief because it's not breaking down very quickly. So you take a little bit more. Your doctor says, yes, go ahead and double up today. Well, that's just causing you to get more and more and more in your bloodstream. And again, you can overdose effectively by taking too much and it not being cleared from your body too quickly. Okay. So these DNA differences can definitely influence your response to the drugs. And today, we do that through trial and error. We have a repertoire that we use, and we give you a drug because we're comfortable giving that drug to you. We base it on your body weight. But really, we want to be able to say, well, let's look at this person's genetics. Let's select the best treatment, right? If codeine is not going to work for them, let's just go ahead and directly give them morphine at a set dosage, because then we don't have to go through the metabolism. Okay? And they'll get the relief that they want. This will also mean that you have less side effects when it's not building up in your body. You don't get the adverse reactions from it. And you also have a better experience, right? You get better faster, you get back to work faster. This also works with things like antidepressants. And so if you get you on the right antidepressant to begin with, then you don't spend weeks coming on to it and then having to come off of it and then going on and trying the next one and coming off of it, right? So all those classes of drugs that Ron laid out for you earlier, those can just be dialed in much more precisely using genetic testing. So with that, I'm going to hand it over to Joe to talk about how to implement this.
Well, thanks, Troy and Ron. And, before I even jump into this, what we just heard was kind of the what and why of pharmacogenomics as it relates to precision medicine from Ron and Troy, two subject matter experts in their fields. And what I'm going to try and walk through is the how do you kind of then take all this information and implement a program within your employer group to have the benefits. And what I really like, one of the things that Ron touched on was, and kind of the topic Jenny talked about earlier of innovation. Pharmacogenomics and precision medicine is kind of the next innovative thing amongst other things that Ron talked about. But when we look at innovation, you have to reduce the signal to noise ratio because there's a lot of things out there. And I think with what, when you're looking at anything as it relates to pharmacogenomics, whether you do it the way we're going to talk about it today, whether you're going to do it yourself, whether you're going to find somebody else to do it, or you're going to do it the way we're talking about, this is the right way to do it. And Ron talked a lot about a lot of principles and fundamental elements that are needed to be looked at or contained in a program for it to work. And then Troy touched on a lot of the science of the lab and the genomic testing that correlated to what Ron talked about. So we're just going to expand upon that as we walk through this. And then at the end of the day, we're looking at taking a pharmacogenomic test and then have the doctor and the patient connected with the knowledge of genomics relative to the disease, the condition, and the drugs that people are on to then take the appropriate action. And I love the way Ron said that, is like, what can I do? And then what should I do relative to all this information? So with that, we'll get started. I'm hitting my arrow and it's not going across, Jenny, so I don't know if you can advance. So a lot of the things that's really important is to not just take a genetic test and then get a result in the hands of a patient or a member, because they're not going to know what to do with it. So what we've done at Wellvia is leveraged a platform that incorporates not only an 8,000 physician network that's well versed in genomics, but then able to build that around the member. So first of all, you have to be able to identify. You don't do pharmacogenomic testing on an entire population. It's not warranted. So you've got to be able to stratify a population and get the right people into the program based on a lot of different criteria. And we have a very sophisticated algorithm for polypharmacy, and then some other indicators to get the right stratification, identification, people targeted for the program. And then we have the virtual telehealth platform, which makes it easy and convenient where people, to whether it's Ron's point or even going to Troy's lab, they don't actually have to do that. They don't have to get in a car and go somewhere. Doctors can talk to patients on the phone before they even get the test, walk them through what it's going to be, and we'll walk you through some of the details of that without going too deep. But we've got a national telehealth virtual platform that's longitudinal around the member and around the provider for specific guidance as it relates to pharmacogenomic testing. That is getting the test done and then what's actionable. again, I think Dr. Leopold touched on, you really want to make sure you're using a best-in-class lab and the certifications and all those points, which is where we've partnered with Kylos that has all those things and focuses in on their testing. And I think Troy touched on DNA sequencing as a method of testing, but it's very detailed to a point that Dr. Leopold touched on earlier, and that's eliminating false positive, false negatives by getting into that expansive testing where you're not just testing 2 base genes out of one assay, and you're testing 11, 12, 13,000 to really get an accurate result. It's a big difference between the labs that are out there and how they're regulated. And then simply what we at Wellvia do is not only provide that longitudinal platform for the providers and the members pre-test, during the test, and then after, and then but this lives in a platform for years. Their results live there. They can hear recorded messages, and it's longitudinal. And the main thing is with any innovation, right, is to keep it focused on convenience, simplicity, drive up the engagement of the right people, and then the results are what matters to the employer groups, because they're the ones to the guidance of the locked-ins of the world that'll be deploying these programs, and they want to get the benefits, either health enhancement or lower cost as a result of whatever program they deployed. So we'll walk you through that quickly, and I think get to Q&A after that. So briefly at Wellvia, what we've done, we went out to the marketplace with a telehealth population health model, and then we went out there, and as the previous session indicated, there's 31% of employers have on-site clinics. So we developed an on-site clinic model for PGX testing, where those doctors can talk to those employees about the test that they should probably take based on certain indications. And then they actually we're able to deploy the test kits to those clinics. The tests are then done, and I'll walk you through the further downstream process there. But we have an on-site clinic model, which is very effective and leverages a cost and an access point for employees to make it easy. We have what we call a telemedicine or telehealth kind of population health model where there is no clinic. And that is where, we work together with benefits consultants and brokers like Lockton to come up with what should be the targeted population. And then we have our doctors through a virtual network reach out and have those conversations that Dr. Leopold talked about earlier about what the test is, why you're going to get it, and then they receive the test kit. And what we find is that through that model and portals, both for the providers and the members, they're able to have much higher engagement and much higher RX conversion because, and I think we heard some of this in the last panel discussion, but we struggle with this a lot in healthcare, and that is what's innovative, right, can be so new that the result's not achieved. The asset's deployed, not a lot of people use it, or the action's not taken, and the benefit's not derived. Well, we follow this all the way through a portal and through a longitudinal care where we see the high RX conversion from, as Troy mentioned, maybe the wrong dose. And what we're going to keep talking about is always the right drug, the right dose at the right time for the right member. So within these two models of employer-sponsored models of PGX, we're able to deploy those and see fantastic success. And again, broken button. Here's a quick, kind of walkthrough of it, kind of a difference. And early on, I think Ron chatted about like 23andMe or Ancestry.com, which is basically, member directed, just getting a test, and then they figure out what they want to do with that, right? This is where we work together in a very sophisticated way behind the scenes to work with the employer and look at claims data, whether it's pharmacy claims data, medical claims data, other actionable data to kind of focus in on who should be getting a test, and then have somebody from our virtual network to make it easy call the member. Then once they've been aware of what this pharmacogenomic test is and the benefit of it, it's then shipped to them. They then take the test. They then ship that back. That goes to our best-in-class lab in Kylos, and that's where the after the test is done, you get a very personalized report that touches on a lot of the key areas, Ron, that you talked about. That Kylos has a very not only precision medicine but personal kind of, it's all the person's own medications on there, and then what is their genetic makeup that has an effect positively or negatively on all of those things, and you'll see that in more detail. Now that result goes to the member, goes to the doctor. There could be other discussions had with pharmacists and other physicians, and then that lives for, as Ron talked about, 2, 3, 4, 5 years, where if other things come down the road, that we're able to look at that member's genomic report, and then they're taking a different drug or there's a new study out, there's no new test that has to be done. They can actually make the adjustment based on what's already there. So a very valuable test that lives on. So with that, I think we'll process through the next slide. The importance of a platform is more just leveraging technology to make this easy for members, patients, doctors to have access to the information. We're amazed to see a lot of the different things out there in the marketplace where tests are ordered. Nobody knows if the patient got the test. Did they take the test? Did the result get there yet? We've built a pretty sophisticated platform that ties into all of our partners and is able to deliver this message in a HIPAA-compliant fashion to both doctors, genomic counselors, members, and others. And that's a big deal because it's not just about taking a test and then you're done. It's about seeing that the results were done. Did you change the prescription? Did you change the dose of the thing that you found out to metabolizing improperly? So we have all these online tools where if something's not done, we're able to leverage those tools to reach out and either facilitate a call on behalf of one of our physicians or out in the marketplace directly to the member. And it's very powerful and drives our engagement rates and conversion rates very, very high. And again, this is just a very high level overview rather than going into the details, nuts and bolts of what a platform is, but it's longitudinal and provides great benefit, and it lives on. And these phone calls between the providers and the members are recorded. So members can go back. A lot of times when providers are talking to members, they've got so much on their mind, they're overwhelmed, the listening doesn't quite occur. So they're able to go back into their own portal and say, what was it Dr. Leopold mentioned about my CYP2D6 and my result in the test that I got from Kylos? Well, they're able to go back and replay that whole conversation at a moment in time when it resonates with them more. The sophistication behind this report that we've joint developed with Kylos gives patient-specific medications and then simple red, yellow, green highlights. And then also one of the things that Troy touched on, but it's very important, Ron touched on it earlier in his presentation, is there's a lot of studies. The human genome's been around for a long time. There are certain studies that are out there, whether it's CPIC or the Dutch Working Group, that have done multiple studies, and the significance of those results for those genes in that drug is very, very high. Studies have been done over and over again. This shows up in the report. There's other studies that maybe have only been done once, that your indication will then show that, hey, this is an indication, but it's not 99.9% accurate yet. It's just some good guidance for you to follow. And that shows up in our report. But each specific patient gets their own medications. And if they're all green, they're fine. If there's red, they need to alert that to their doctor, and then make a change. It could be to get off a drug or change a dose, or yellow could be the same thing. But there's detailed information. There's also a gene summary for that specific patient. We can go on to the next. This just gives you the specificity and sophistication of this report. Like there's also current medication interaction summary. Are there drugs that I'm on relative to my genes and or not that I shouldn't be taking together? And these things avoid ADRs and other things down the road, which is not just, again, we're talking about enhancing health and lowering cost and eliminating errors. So this information is very powerful combined together, and it comes in a summary format in the first couple of pages, and then for the real geeks in the either on the provider side or the patient side, they're able to look at the detail, because Troy, I think we're up to what, about 28 or 38 pages in a full report that gets into every gene and anything that you might, you know, find relevant if you see it down the road. So that's the, you know, current medication interaction, but you know, and you also need, you know, a medical action plan that needs to be followed through by the provider and the pharmacist, which is all guided by this report and shareable by the member and or prescribing doctor to other doctors, because we all know, as Troy touched on, as you get older, you are on more drugs, and then you're also seeing more doctors, right? So it's important to be able to share this information with multiple physicians, again, in a HIPAA-compliant format, which our platform does. So I'll pause there and go to the next slide and wrap up so we can get to Q&A given the timing. Yeah, a lot of this I can leave in a follow-up report or leave behind through Jenny. So basically, you know, when you look at pharmacogenomics is an innovative way to kind of eliminate trial and error, which is nothing more than inefficiency, right? So this is a way to get very precise at the front end. Instead of a doctor saying, hey, try this dose, that's the protocol, you may need more or less than this, come back in 3 months. That prescribing doctor is able to tell today that Joe's dose, to Ron's point, is half of that of somebody else based on the genes that showed up in my report, and can start me on the right drug today, which eliminates waste in the wrong drug and then potential elimination of complications down the road, especially if I was supposed to be on something like a thinner that wasn't working for me at all. The way I'm going to find out about that is 4 months down the road when I have an adverse event and I end up in the emergency room. So we're able to see all that today. But the main thing in any innovative thing, as we've all talked, the three of us have talked about, Ron, Troy, myself, is that innovative things in healthcare are about enhancing health and lowering cost. And pharmacogenomics is just one tool to be able to do that in kind of enhancing the health of members. And then obviously there's a cost reduction, which is very compelling, which the lines cross it depending on how well you implement a program and the cost of the program, somewhere between 6 and 8 months, which is quicker than most any other program that you can implement within your employees. But you have to do this alongside everything else in that patchwork quilt of benefits that you're offering to your employee population. But again, right drug, right dose at the right time lowers medical spending and enhances health. So I'll pause there and turn it back to you, Jenny, I guess.
Thank you so much, and I appreciate all three of you. That was very excellent and detailed information, and I think it did raise quite a few questions. The first one I have is for Dr. Leopold, and I'd like to just jump right in if that's okay. How do you view PGX testing adding value to employer groups and their benefits and employees? I can't hear you.
We will gauge we will gauge what the employer's interest is. So in some cases, in most cases, an employer who voices an interest in pharmacogenomics testing is looking to, I say, lower medical costs and then improve the health outcomes, the clinical outcomes of the treatments that their employees and their families are getting. So I think there's a big educational component initially. Much of what I talked about, and I think both Troy and Joe reinforced some of the comments I made, and likewise mine hopefully were contributory to their points. I think there's an education that needs to get done here. So once educated, then we can start making recommendations around what they want to do. So some of it is, what will their carrier pay for or not pay for? And then to what degree do you want to be aggressive with regards to reaching out to your client? So in some cases, the identification of who would benefit from genetic testing might be a questionnaire. For pharmacogenomics, are you on any medicines in the following classes? Or are you taking any medicine for listing conditions? Is one way that a lot of organizations get at it. Another way might be, we want to see your claims data, and then we could reach out to those people. There will be clients that will definitely not want to do the latter, but okay doing the first. Second is, who are my employees, and what is their willingness? What is our culture to make this available? How would we make it available? How would we notify them? How would we place our relationship to this new capability that we're offering needs to be considered. And so the way in which that is done is very important and matters. And it's very different for a manufacturing factory floor of 3,000 people or 3,000 people strung across small retail operations across 40 states. So that's very different. And then finally, looking at the vendors and understanding, what are they testing? How do they screen for the testing? What is the experience? I think Joe did a great job of laying out what Wellvia offers, and advising them and comparing different solutions against one another in terms of what is the employee or member experience, what happens when they're tested, what are you testing for? What is the estimated cost to me? And is the estimated cost based on an appropriate amount of testing or too much testing or whatever? And then, as we've discussed, what happens once I get the results? What happens with me? And if we're talking specifically about pharmacogenomics, a point that I didn't bring home, but I think Joe did. Troy, I think you touched on this as well. Talk to my doctor, because my doctor may or may not be familiar and or comfortable with some of the results and what their implications are. So those are some of the things that we would look at.
Excellent. Thank you so much. And I think that latter comment that you made is so imperative, because, you're right. A lot of the doctors just don't have the information at their fingertips. And so having that next available conversation through a telemedicine platform might help even the doctor, to understand it better, like Joe had touched on. So thank you very much, Ron, for that. And, I have another question here. This looks more like it might be for Troy. What differentiates PGX labs? Maybe you can answer that, or?
Sure. Yeah, I think, it was touched on, I think, by Ron and Joe a little bit there, that, really what you need to look at is, how do they approach it, right? What is the quality of the information being produced, and how is it delivered? It's often easy to perform a test and give back a lot of statistical information, right? Some curves and some ranges, but really, especially when it comes to genetic information, it's often hard to interpret. Right, especially if a physician has been practicing for quite a while, maybe didn't have a lot of genetics training early on in their career, right? So how do they take that information in and really effectively apply it, right? And I applaud all those that sort of do stretch, right? They want to learn, they want to know how to employ this to have better outcomes for their patients, right? But there's also a lot of misinformation out there, right? There's a lot of data to go through. So I think really being able to select a high quality lab, one that's really committed to showing you the data, showing you the science behind it, right? How did they come about this information is really important. And you should ask a lot of questions of the laboratory that's doing that work.
Thank you for that. Another question that's listed here, I think, Joe, you might be able to take this one. How does telemedicine platforms like Via play a role in pharmacogenomics?
Yeah, good question. I mean, the reality behind innovation in healthcare, members, providers doing something new, the easier you can make that for everybody, the more we'll all get them to do what we call the next right thing. And a virtual telehealth platform that's comprehensive, how does that make it, why is it important? Well, if you don't have some sort of virtual way, and that doesn't always have to be video, it can be telephone, it can just be a platform in general, but if we're back in that situation where we have to drive to a lab or drive to a doctor's office to have a discussion, drop the kids off at school, and then get to the doctor's office, just like telehealth in general and digital therapeutics and so many other ways which we're leveraging technology. That's the same in leveraging telehealth in the pharmacogenomic arena. What we saw early on was a definitive need, to Dr. Leopold's point, of you need to have some sort of clinical discussion that touches on not only clinical but science of pharmacogenomics with a member before you just send them a kit, right? And if you made members go to the doctor's office, drive there and take an hour and a half out, as opposed to a virtual visit, to have that awareness, that education, and then getting that patient comfortable and excited about the test they're about to take, is really how you leverage a telehealth platform properly at the front end. And then we do things on the back end after the test is taken that cost money. I mean, we have doctors reach out to patients after they've gotten, because the doctor gets the result of the patient first. And when I say doctor and I point to me, I'm not a doctor. But the doctor gets the results, reviews them, and then calls the patient, or has a video chat with the patient. So as you can imagine, leveraging a core Via asset of a telehealth platform, one of the largest in the country, we're able to reach out to the members and make it easy, simple, and convenient for them to participate in this very cool new initiative. And then from there, once the results are disseminated to the member, there's other conversations that have to occur. There may be other providers that need to be talked with about the results, or the results sent to. And then there's a pharmacy that ultimately has to get called by somebody to get this patient on the right dose or the right drug. So all of that is provided in a platform and cannot be done on a one-off basis of just the test.
Thank you. I want to pause here for 1 second. We do have one more polling question that I think is really going to kind of give me a temperature of how our audience is kind of dealing or understanding what we're presenting, and I think it's important to get that. So based on what you've heard, are you interested in personalizing employee health with confidential pharmacogenomic insights? And I'd like to give a couple seconds for you all to just quickly, fill out this poll. It's open. Give a couple of seconds for folks to answer the polling question and re-engage our population here, if we could. And just a couple more seconds. So I think that's interesting. So we have, a good portion that say maybe, but let me learn some more. And that's, I think, what our job is, at Global Healthcare Resources, is to bring these kind of compelling conversations together another equal parts that say, I'd consider it, I'm ready to do that, or I'd recommend it to my employers. And I think, there's a lot of heartstrings that can be pulled as it relates to this. And, we are right at 4 o'clock, and there are quite a few questions we want to get back to. But I'd say, that's really, to me, very compelling and telling that folks would, understand what we've just said and then understand the benefits. And I think, given more time, we can answer a lot more of these questions, and we will get to those as well. Maybe we can take one more, if that's okay, for you, Joe, and Troy and Ron, please feel free to weigh in. We'll ask this one question: how do you help employers understand the significant benefits of pharmacogenomics through education, obviously? But love to hear your thoughts, Joe and Troy.
Yeah, I think you'll Jenny, you gave me the kind of easy answer to just question to frame out the answer, and then I'll turn it over to the scientist and the clinician to answer it. But what we've put together is a platform that offers pharmacogenomic testing in the way that it needs to be done. Again, whether you use us or use somebody else or you try and do it yourself, this is the right way to do it. As opposed to the question of like, how do you do this within a population? We leverage the key subject matter experts of clinicians like Dr. Leopold and key genomicists like Troy Moore at Kylos to be alongside us when we're having the conversations with the employer groups to get into the real clinical scientific side, because I can talk to the high level, right drug, right dose, right time type discussion, or high level DNA sequencing versus other less appropriate options for DNA testing. But it's having subject matter experts like Ron, like Troy, together with us at Wellvia while we're talking to the employer group. So I'll turn it over to both Ron and Troy to kind of expand on that answer,
sure.
or at least try and clean it up. No.
Troy?
So I think, one thing that often gets overlooked is there's not one right solution. So I think, as Ron was saying, you really have to fit this into your benefits program, right? And each company is going to have, things that are important to them. And genetics goes right along with that, right? Pharmacogenetics, there are, depending on your employee population, right, there are different aspects of this that could be very beneficial. All of them won't apply. And so you really need groups like that can bring together expertise, right, to walk you through it and help come up with the best plan to fit those needs, right? Sometimes genetics get sold as, sort of the answer to everything, right? And it's really not. Like any other part of healthcare, there are things that are right for your population, things that aren't, and you really need to bring that team together to help get the right solution built up for them.
We're talking about pharmacogenomics. There is an opportunity to reduce cost. That can be evaluated, and so looking at what an employer is currently spending and thinking through or running an opportunity analysis for introducing this is an important piece to figuring out if doing a cost benefit. But in addition to that, obviously better outcomes, people on medicines being treated more effectively with less side effects is always a good thing to strive for. And for some employers, that's very important. For others, it's important, but maybe not highest priority. Helping them sort out their own priorities and putting this in its appropriate place.
Well, with that being said, I want to thank all of our prestigious speakers today. A very special thank you to today's host and sponsor, Wellvia, and the team for making today's webinar possible for us and educating our employers and brokers and providers out there that are really looking for innovative solutions to help their self-funded clients. And I got to tell you, there's a lot of heartstring stories that we can talk about where, you've gotten the wrong medication and it's just, it can be a very big nightmare, and just the ons and offs and, many different meds to find the right treatment. It doesn't just affect your employee, it affects their family and their well-being and their presenteeism. So that we can go into that, I think we should in a future conversation. But again, utmost sincere gratitude to you, Dr. Leopold, Joe Connolly, Troy Moore, We wish each and every one of our attendees today a fantastic rest of your day, and we look forward to seeing you all next month for our virtual summit in March. We'll be talking about chronic disease and probably talk a little more about pharmacogenomics as it relates to that as well. So I think it's a really valuable topic. I hope you got something from it. Thank you for your participation in all of our polling, and just thank you so much for everyone joining today.